So I'd like to invite Dennis up here to kick us off a little bit more, give a little context to the conference, and introduce our panelists and facilitate our first discussion. Thanks.
We'll probably have some more folks joining us. We have a lot of name tents back there, and I guess folks are probably knowing the area. They're probably out on Highway 36 in a traffic jam and construction somewhere between here and Denver. That's my usual experience. Well, first I wanted to we have some people that we met with this morning, and then there's a large group of you that are new to this. So I'll start this off by welcoming you to the Western Interstate Commission for Higher Education. WICHE is celebrating its 60th year this year, established by Congress in 1953 and signed into law by President Eisenhower that year after the majority of our Western member states ratified the Interstate Compact. So, you know, we're a venerable old organization that has been serving the West for well over a half a century. The mental health program at WICHE was founded in 1955. We're one of the oldest programs in WICHE, and our mission is really to help support our member states in improving their services to people with mental illnesses, substance use disorders, and increasingly we're becoming just as much involved in really the population writ large, healthcare, the integration, behavioral health, and general health care. And we even do work quite frequently with persons with developmental disabilities around those services. So you can't work on innovation, system improvement, measuring what's going on, and then not think a little bit about workforce development. So the other big component that we work on is workforce development and really ensuring that there's a quality workforce to work in those systems that we've been working to improve. And so we really have a dual education and technical assistance research mission. We're embedded in a much larger organization. WICHE is for most people in the West, what they know WICHE for is our student exchange program. At any given time, 32,000 students in the WICHE region are in exchange programs, moving from one state to another to be able to access education that's not available in their home state. About 28 to 29,000 of those students are undergraduate students, and they're able to attend schools at over 250 public institutions around the West, both at the community college and the baccalaureate level, for up to $150,000, 150% rather, of in-state tuition. Doesn't mean that all states charge 150% of in-state tuition, but that is the cap. To give you an idea of what that saves people, a family in our region, one of the top destinations because of programs in hospitality, in the hospitality industry, is the University of Nevada, Las Vegas. And each year that's one of the top locations for undergraduate students. And if they hit the difference between the WICHE rate at that school and the non-resident rate is $11,000 a year. So that's what it means to individual families, individual students in this region. At the graduate level, we have 800 graduate programs around the West that students can move from one state to another. And in that program, you pay 100% the same as in-state tuition. So you pay resident rate no matter where you go, whether you go to the social work program at Colorado or Utah, or whether you go to one of the other programs around the region in mining at the South Dakota School of Mines is one of the top schools for preparing engineers in the region. And then finally at the professional student exchange, a number of our states, Wyoming, Montana, Idaho, et cetera, do not have medical schools. Some don't have pharmacy schools. Some don't have dentistry schools, OT, PT, a number of mostly health professions. We used to have law in the professional student exchange, but unfortunately or fortunately, depending on where you're sitting, every one of our states now has a law school and produces lawyers in abundance. And so that's sort of the part of WICHE that most folks know about. And when we go out and we talk to the general public, that's what they know. The majority of the legislators in this region were WUI scholars that they went to college through because of WICHE. That's where they went. That's how they got through school. Almost all of the physicians in this region went through the professional student exchange. So when you go out and you start talking to people out in the real world, a lot of folks know WICHE. What's even funnier is some of them actually know the individual programs, and they'll go, "Oh, you know, I was a WUI student," and then we'll go, "Well, that is WICHE." When we go out and we talk, people we meet with in the mental health world, they basically are sort of surprised to know about all that higher education stuff that we do, because they've dealt with us for over 50 years in the mental health arena, and so it's always sort of an interesting interface. You guys are called here through a program that we've been working with for at least 15 years, if not longer. Chuck, when did...
I think WICHE supported the MISSIP community when it first started, and then continued through the DIG grants that the feds have given, or is still.
So we've been involved in helping support the Western States Decision Support Group for a long time. And we're one of the only regions in the country that really pull together to the degree that we do to share resources and to really try to build a substantial community, if you will, around data, around measurement, and really around using data to guide care and to improve services. It's something that we've been committed to for a long time. The states in our region pay a small support fee of $6,000 to be a part of the Western States Decision Support Group, and that allows us to both work with Olinda and the other folks at SAMHSA to manage the effort, but then it allows us to have an extra meeting a year face-to-face, and it allows us to do some other things through the course of the year with our listserv and telephone calls and things like that to really try to use these resources. Because look, in many of our states, when you start looking at the team of people that are involved in working on data, in some of our states, that meeting actually can occur in front of a mirror, because that's the team. It's the person doing the data and who the other person they're looking at, their reflection in the mirror. And so most of you work with a very thin staff. And so by having the Western States Decision Support Group, it really affords you the opportunity to learn from each other, support each other, and get to know what other folks are struggling with, and sort of how they figure out how to do something. So that's why we come together here when we can to do this once a year. One thing that I think that is extraordinary about your effort is since its inception, it's always included consumer membership. Consumers have been at the table with you to give voice from the side of the consumer to data and what we're doing around data, and so that consumer voice has always been a big part of what we do as well. So that's sort of the history and sort of a ramp up to this. This first panel today, when Chuck and Nate and I were talking about this, one of the things that I know that when we've worked with the Western States Decision Support Group a number of times over the years, it's like we bring all the data people together, And they'd say, well, yeah, but my director, I don't know what my director's after something, and they're under some of these pressures, and we're trying to get them the data that we need. But we don't really get to spend a lot of time with the directors, and that there's oftentimes, it's a subordinate, superior role, and it can kind of get a little dicey sometimes. The other thing is that the directors oftentimes don't know about the Western States Decision Support Group. And, we get the invoice out there and they go, well, what's this and why are we doing it? And so one of the things that we really wanted to do in this meeting by having the Mental Health Oversight Council right before this happened, which are the state mental health directors in our region, and then this program following it, was to sort of afford the opportunity to bring those two folks together, those two groups of people together, to sort of share some of the same turf in a more relaxed atmosphere than saying, this senator's called me and we need data about this because we have a hearing tomorrow. So that's the purpose of this first panel that I'm going to moderate, which is really to just sort of get a perspective of directors about what the data needs are, data changes, what's going on. We're in this big process of culture change. Data, and we're integrating mental health and substance abuse, where most of us are alive, well, and immersed in that. We have states like South Dakota that are bringing mental health from corrections into the fold. We have some states that are integrating in services for developmental disabilities. Overlaid with that is the Affordable Care Act and the interface with general medicine, primary care. We've got all these new kinds of folks coming together, and the data demands of those different entities are falling in our lap, and we're trying to figure out how are we going to jungle all this, how are we going to work with that data. And the one thing that we thought about a lot is that we're not talking enough about what are the different cultures. Because for many of us in behavioral health, in mental health, substance use, and developmental disability services, our data comes from a culture of social welfare. Right? Our culture was driven by a social welfare rubric and a social services rubric. And really, our culture was one of retrospective look at data, and the purpose to do that was to justify our existence. Most of the time that we've used data in our field in the past was really using archival data to prove that the scant resources that we were given were used properly. It was a rubric of justification. And almost always it was a look back rather than a look at and a look forward. We basically been playing catch up for the most part. A lot of times we're called upon, I know I was in this role, I was a director in Nebraska, and the role I was in most of the time with data was that hearing I was talking about, and somebody was trying to cut my money. And I was going before a panel to prove to them that actually the investment that the legislature was making was worthwhile, and this is why, here's the data that showed it. And, a couple of times I got to tell you, I got a little note passed to me and said, could you hurry up, you know what we want to do, we don't really need to hear this data stuff. True story. And my fellow panel here, Carl Brimner, a longtime colleague of mine, was the state mental health director in Alaska, began the effort there to integrate mental health and substance use services, went on to a similar role in the state of Washington, and then worked at the county level in Oregon, in Multnomah County in the Portland area. So the perspective he brings is from two different states, three different states, 2 state roles, and a local role. Corey Nelson comes to us after running a state hospital in the state of South Dakota, and then running a state hospital in Arizona, and now being the director of behavioral health for the state of Arizona. And I just thought we'd just sort of go through a little bit of a dialogue, and we really hope that this can be interactive and participatory as we go along. We don't got a lot of time here, but the time we do have, we just wanted to sort of share, what's it like to sit in their chairs and do the job they do, and what do they ask, and what do they see changing in data. So I'll start with the sort of the first question I had is, how is data used in by behavioral health leaders? Why do you need it? Who asks for it? And I'm not sure all the time that the data folks that work with really understand the pressures and where those pressures are coming. So if you just sort of show, who's your customer for data? And how's it used?
Sure. Thanks, Dennis. I think that it does change, as Dennis says, and I think the other thing that's really important to keep in mind is that we've been a system for decades of just justifying what we do as opposed to looking at it from other perspectives. I think that when I was a mental health director, there'd be times where having data available to me to be able to recognize that there could be some problems in the system that needed to be taken care of. An example of that would be something like if we were getting, when I was in Portland, Oregon, we had 5 hospitals in Portland. And if we started seeing a growth in readmissions of individuals that had been hospitalized for brief times in one of the hospitals, that led us to believe that we need to either be doing something different, or what we were doing, we weren't doing very effectively. So there's that kind of a thing that exists as far as I'm concerned, a way to use data. Another has to do with just planning that, and that does become more just justifying. It's kind of like, what do we need in our system that we don't have now? When I was in Washington, one of the things I got identified was that we had ACT teams in some of the urban areas, but we didn't have them across the state. We started looking at the data in terms of how we could use, would it be useful to have ACT teams across the state? And if so, what would that look like? How many people would be in the teams? How many teams would we need, and so forth? And so those are ways that have been really effective in terms of being able to use data. Just stop. Or you want to jump in?
Yeah, unfortunately, I think in behavioral health we're still behind the curve of where we need to be. I kind of look at it as, in some ways, we're where the old unemployment offices were 15 or 20 years ago, where their reportables were, how many people did you get signed up for unemployment? And then they went in and said, we did our job and we expended our money because this many people came in into the door to sign up for unemployment, and we got this many signed up for unemployment. They had to change over the last 15 years how they did their business. It's no longer how many people they got signed up for unemployment, it's how many people they actually got back into the workforce. So we've got to start taking that simplistic approach back with behavioral health and look at that, because when you look at who our customers are, our customers are the legislators, our customers are as much as I hate them, the media, our bosses, the governors that we have to report to, and the biggest customer that we have that we forget so many times is the individual that's actually receiving service. That's where the rubber meets the road. And if we don't start showing outcomes in our data in real time and then making decisions based on that, we're doing an incredible disservice to those individuals that we're trying to serve, as well as the taxpayers that are supporting all of the services that we're doing. So that's how I look at it. And it's real time coming at you from all those different directions, and that's why you guys get the requests that you get from us sometimes.
So that's a good segue, because the next question I was thinking about is sort of, what are your big challenges? What have been your data challenges in that environment? What are the challenges that you faced, sort of meeting those demands?
I'll start, kick back to you this time. Pretty much when we get a data question, it generally rolls around 3 areas. How many are there? What's it cost? And does it work? Okay? Those are the 3 general areas that are coming at you. Whether it's a news story about how many people have had have had competency restoration, how many people are getting peer-based services, what's the cost, where are they, and does it work? And for the most part, we can get how many are there and what's it cost, but we don't do a very good job of saying, does it work? We've not figured out how to roll those outcome measures into it so many times. And the other thing that's a great challenge for us so many times is that the data's not current. I mean, there's always a data lag. We're using, well, last fiscal year we did this, or over the last 5 years, here's what it's averaged. It's not how many are there today, or how many were there yesterday. Real-time data in the world of iPads and everything else, people want to know what's happening now, not what happened last year, and that's incredibly challenging for us to produce. So as we continue to develop our data systems and our outputs, we've got to look at those real-time applications and dashboards that you can pull up immediately and answer those questions.
And I can't agree more with what you're saying. I mean, the only thing I would add to that is that, part of the pressures that state mental health directors are under is, how do you get that data? How do you get the data from either the local government entities, if that's the way your state is designed, or how do you get the data from providers direct? Because everybody's not working on the same system. And that becomes such a huge problem in terms of not only getting real-time data, but sometimes getting any kind of data at all. And so it's like, one of the things that we have to sort of solve in the future, and I think we may get pressure on this more than in the past, because like Corey says, legislators are our customer, and they're the ones that we really have to give the information to. Well, we're going to be facing another customer even greater than what they have been, and that's going to be CMS and Medicaid, because they're going to be looking at what are your performance outcomes, because we're going to be giving you money in the future based on your performance outcomes, not based on how many people you served or anything like that. So we're going to have that data in the future that we don't have today, or we have it on a very limited basis.
So you guys have been doing this each of you have been in this field for well over a decade. What are the changes that you've seen around data and evaluation? If any, what are the kinds of changes that you've seen, and the kind of data that you need because of those changes?
I think the kind of data has changed. I mean, and it does get to the question that Corey mentioned earlier, that it's like, how well did we do? Did this really work? And I think, we've been thinking about and operating from that question probably for the last few years now. And sometimes we have an answer for that, but when you look across the system and across the services that are provided, we don't always have answers to those questions with everything that is being funded and that's being provided in the community. And that's still a huge challenge as far as I'm concerned. Something that so there is that change, and I think we're meeting it to some extent, but not nearly as much as we need to. I think the other interesting, we were meeting this morning, and one of the things that came up was how the data, the encounter data, and how important it is to have that, and the feds want it and so forth, and the states want it as well, and that's all based on individual stuff. Well, that's great. It's great to have that data, and we have to have that data. But then we have to have the data in terms of how is the system as a whole. How are given services and specific communities working or not? I think that's another area that's a challenge.
I've been working in the public sector now, my 23rd year. Unless you add the 2 years I was on probation, it's 25 years. And what's changed from that time frame is we've gone really from output to outcome. It's just that simple. We were always asked before, what are our outputs? And now we're really looking at what are the outcomes. That's where we got to go. We're getting much more of the return on investment questions. And we should. Carl and I were talking earlier about how we really have to start looking at things in a more business decision approaches. So many people come to behavioral health because they want to help people, and we get that, but we can't help people if we don't make good business related decisions. so many of us have come in and we've had that one-to-one relationship with helping people, whether it was in a clinical setting, whether it was in a community-based setting, or whatever it is. We've got to get past that one-to-one and really look at the macro and how we make those impacts. So when you talk about new areas of data that we're looking at, we really have to go that next mile and see where our data and our services are touching those other places and be able to respond to that. You know, for example, I mentioned South Dakota with corrections and the mental health in there. How is our mental health system impacting the correction system? How is our mental health system services we're delivering impacting the number of people in jails? How's it impacting the police department? Is it taking their police officers off the street, or are we making it easier for them to make decisions on the fly, to be able to get people into the right door to start? How's it impact ERs? Are individuals who are needing service waiting in hallways in ERs, or are they able to get into the right level of service in a timely manner? And is that making it better for everybody? First and foremost, the individual who needs the service, then the ER medical providers, and the police department, who's the first level of contact. So we're really getting towards that next level of data, of interactional data. Same thing with like the child protection system. You know, most of the kids in the child protection system and their families are interacting with the behavioral health system. But so many times we don't correlate that data and go in there together as departments and say, you know what, this is what we've done collaboratively. Here's the data to support it. Here are the outcomes related to it. So, I mean, we've really got to start stretching our thinking and get out of our own little lane and realize that we're part of something much, much bigger now, and especially as we're going down the Affordable Care Act road and some states that have done Medicaid expansion or restoration populations. It's sort of that brave new world, but it's an incredible opportunity ahead of us. That adversity creates opportunity if you choose to look at it that way.
One of the things that I've heard from the field when I'm out in the field and I'm talking to folks in the provider community is that they say the state, the state, they know how to add, but they don't know how to subtract. That as these data demands come, you add those data demands, but as these things evolve, that don't remove those old things, and so that in many cases we're still counting the widgets like we used to while we add on the outcomes. So we still are doing the output system, and now we've added on the outcomes, and so we don't seem to take away what we say we don't want. And so I was just wondering, in your practice in leading states, were you able to accomplish that and really being able to say, okay, we don't need to, we're going to ask you to do A now, so you can stop doing B?
Yeah, I mean, I think, from my perspective, I think we have, and we work very closely with our providers and our contractors to determine, what data is important anymore to make the decisions, and if it's not needed anymore, let's drop it, change it, prioritize it again. We're really trying to take that business-related approach, and if a business is looking at its 1, 3, and 5-year strategic plan, their 5-year plan isn't the same as their 1-year plan, so they don't need the same. We've got to look at that and evolve it along with it. Again, Carl and I were talking earlier, and I'm going to throw you out here and see if the bus hits you, Dennis, for a second. And that, I was sitting there, wouldn't it be nice if we got all the WICHE commissioners together and said, let's do something innovative and build a data center for the Western United States that has all the same Common Core data markers that's all submitted in through here, and then the states all mine it back out and use it for what they need it to do. Then you've got one system change. It can change fast. It can change rapid. It's outside the hands of one entity. It's something that would be kind of that dream when you talk about data and transferring people from state to state and making changes and what a potential mine for data and the colleges to use for research and really make a full-scale change in how we do business.
which I think would be great. I mean, I think it'd be great, and I'm just waiting to see what Dennis is going to respond.
He's still standing.
Well, it's interesting. We have floated ideas like that. I mean, that's one of the things. I mean, we are an interstate compact, and so we can do those kinds of things, and we have done in a limited fashion. But you always got to remember that when you sort of begin to talk about building a partnership, then you're also talking about people sharing, and we don't always play well together. And certainly, the last time we sort of bellied up to this, we thought it was a perfect opportunity. It was 2007 and 2008. The economy was tanking, and there were states that were unable to go out and do licensing inspections. It was just flat. They cut the staff that were able to do it. So there were folks out there that were simply no one could go out and do a review. And so we floated the notion on a meeting that, well, maybe what we could do is collaboratively put together a group that worked centrally through WICHE. They do it all the time. That's all they would do. They would learn from other states and how they were doing things, and they could go out and do those, and we could get the economy of scale to make it. I mean, that was just, because that meant that somebody that actually had that job and 10 other jobs because of the organization and really wasn't able to go out and do it, but they didn't want to give that up because it was a threat to give it. So I think it's a great idea. I think it's one of the things that this region has available to it. And I can say that NCHIMS, when we share this. This is a higher education office, and so WICHE's on the second floor, and then on the lower level is the organization for all the chief executive officers for higher education in the West, well, in the United States actually, and then the management information systems for higher education is the other one. The data folks, and they do that in higher ed. They do dump their data, and you can go across the way here, and you can find out data, and Dennis Jones can do data spreads that tell you everything, including predictive analytics. And they're now doing predictive analytics that they're studying students as they progress towards degrees, and they have predictive analytics that say, to the individual level, that says, student A, if we don't intervene right now, is not going to make it. Student A is struggling right now. And they've got those kinds of tools in there, and it's pretty phenomenal what they can do. And now they're doing it with distance education, right? Where people, because now for the first time we have real-time data, people are online doing things, and with predictive analytics you can tell from what they're doing whether they're struggling, and then you can intervene. And so it's rather phenomenal. And you can think what you could do with the electronic medical record along those lines. Because once you put those predictive analytics in there, you could actually, the example I always use is like when you pull up Word, and that little, I always minimize it and get rid of it, but that little icon comes up and it says, it looks like you're writing a letter. You need a little help with this? We could develop those kinds of predictive analytics that say, hey, so, Sarah's having a hard time right here. She's missed this many prescriptions. You need to do something, and we don't. Instead, we wait until someone blows out, and then we have Congress supporting more involuntary hospitalization rather than getting ahead of things. Looking at how can we better engage. I think great opportunities, and the more we collaborate and knock down those silos, I think the better off we'll be. But always got to remember is that when you break down silos, there are individuals in those silos, and they've got to want together. That's a big. But it doesn't mean we have to do the whole region. Would California ever do it with us? Probably not. They're the 8th largest economy in the world or something like that. They don't need to. But there are a lot of our states that I think would make a lot of sense to combine resources and do that. And we'd certainly be game to look at.
maybe that's the way to start. Maybe the way to start is to just have a few states get together at the beginning that are willing to do it, and that spreads, because the information. I mean, Corey and I were talking about it. Can you imagine the people on the East Coast? They'd be thinking, how come we don't have that? You know? And usually it's the other way around. We're looking at them and saying, how come we don't have it? So it's, I mean, it would be.
Yeah, I only say that about Amtrak. Yeah.
Sorry to ask a dumb question, but that's sort of my job. Was curious, aren't the regional health information networks the setups for all the data systems for the national reporting? Isn't that already sort of in place? Couldn't you actually morph out of that? The facility that you're talking about, I mean, isn't there already an infrastructure being built that works for those kinds of data shares?
From my understanding of the health information exchanges is that they're pretty, and I could be wrong, but that they're pretty state bound and not interconnected between. But I'm not. I haven't spent a lot of
problems
time
talking to each other. I'm just saying that they were supposed to be building infrastructure to actually communicate that way. There had to be some common standards.
Good.
Yeah, and I think you're right. Yeah, you've got all the tech people here who can answer that. I mean, I think you're generally right. I mean, that is the general concept, but I don't think the level of data that's collected through there is anything close to what we were contemplating for here, to have full information system operational out of one entity. For example, to me it's similar to VA doesn't do a lot of things right, but its information system is pretty robust. That's one thing that's used across the country. Whatever VA clinic or hospital you step into, you've got access to that information, and it's a pretty solid set of information. I think we could take a little bit of a lead from what they've done and developing how to do that, use it anywhere to do something. So again, this might be a pipe dream, but it's just something that we were talking about how opportunity can grow something.
Well, the standards that would be used would be still useful here. I mean,
Absolutely.
The same standards, so and the data could come and then you'd add service. Yeah, you'd have to decide what you could add. Sure.
Yeah, John.
The obstacles aren't simply technical.
Yeah.
There are significant political obstacles. For example, to my understanding, the single largest source of payment for public mental health comes from the Medicaid program. The Medicaid program in each state is driven by the state Medicaid plan, which also then drives the Medicaid management information system. So if you're going to have common Medicaid management information systems that could all sit in one place, then each state would have to adopt a common Medicaid mental health plan. And the question I would ask, is Arizona ready to adopt a common Medicaid plan with Colorado or Wyoming or whoever? Because that's the first problem you need to solve.
You can take it that far if you want, and I don't want to get stuck on this subject because I think there's a lot of other discussion that we can have. But I mean, part of it is what's the core set of information that you're looking for. It doesn't necessarily have to be, 100% similar across every Medicaid plan. There's the 20 core indicators that you're looking for that get downloaded to here that you then.
I mean, it would be extremely valuable if we as a region could agree upon sort of what would we want on our dashboard, if you will. What was that common core set of data that we all wanted to report, that we want to all measure up against, and then how would we get that data into that system? That'd be extraordinarily valuable. But boy, how to get there is another story. We wanted this to be interactive, so please ask.
Having been a provider on that end of this this situation, I think about the irony that here we have this capacity now to electronically document and track all of this work that we do, and yet what we know now is how little we really know, and we haven't really figured out a way to make those electronics work for us in a meaningful way. And so when I think about this kind of starting small, starting from a set of core measurements that everybody does anyway in some form or another, which I think the this system, the state systems are going to be doing, looking at that and finding a way to take what I've been toiling at the provider level and make that meaningful and help us be more sophisticated, more knowledgeable, more predictable in terms of how we do what we do. It's really a pretty amazing concept. But I do think the burden on the providers is, and I really think the free market economy is this is an area we should have not let it be a competitive market. We shouldn't have had 500 different EHR systems that all communicate differently, don't communicate to each other, and they all use just a little bit different words so that nobody can use any of it. But I do think I think the providers could be engaged in that process if they knew that they weren't going to carry the whole burden, you know?
I had my annual physical a couple weeks ago, and I got this printout in the mail, and I mean, my primary care doc responded to every single test that they did, told me what they meant, what it meant, what those ranges meant, how I was doing. In the end, said, I mean, it truly was meaningful use, and it was interpretive to me. I mean, it was amazing kind of a different relationship than, what I can remember earlier, where you'd go, you'd have it done, and pat you on the back, literally, and send you out the door. I mean, it's how can we change that so that the folks that we're working with, our consumer partners in care, how can we change the relationship so that when they walk out of a visit with us, that we've given them some kind of point of care information that helps them understand how things are going and what they need to do. Because I don't know that we do that. Because I think we're still pretty retrospective in our data and archival in our data, and rarely are we collecting data at the point of care that helps either the provider do a better job or the consumer to understand how things are going and to provide input. All right. Well, kids, I hope this was valuable to you. It's certainly, if nothing else, it was a way for you to settle into WICHE for the afternoon and the day tomorrow. Thank you again for being here. Thank you, Carl.